In the preliminary reading I was doing about non-communicable diseases, I was reflecting on the fact that we have, at the moment, an extraordinary focus around the world on Ebola, a communicable disease. It is exercising so many people's attention. It is calling forth an extraordinary collective response from some countries, if not necessarily every country. But sitting underneath this, hidden beneath the surface, is something that has far greater potential to have a long-term impact on our world today. Not just a health impact, but an economic, social, environmental impact on the world. We heard Dawn speak this morning about wicked problems, and I think non-communicable diseases clearly falls into that category. Not just the economic impact that it has and the environmental impact, but the political ramifications, the complex constraints that exist, and most particularly the enormous human impact. It's an issue that's very relevant for us in Australia, as I'm sure that we'll hear. And Dawn made reference to 91% of deaths being linked to non-communicable diseases. It's very relevant for us as a partner to Pacific nations, and it's wonderful having Filipe here, who I'm sure will talk more about that. But non-communicable diseases within the Pacific have reached epidemic proportions. And it's extremely relevant to us as a partner within the Southeast Asian region. I was looking at one of Rob's papers, and there was reference to 10 times as much being spent on tobacco in Bangladesh as there is on education. And there was reference to almost 70% of adult males in Indonesia smoking. We will hear more from our experts today. So what we have here is not the big headlines, but it possibly should be. And this is to refocus our attention, our individual attention and our collective attention as Red Cross members on something that is causing not just the human suffering to so many, but the economic and social and cultural and environmental impacts. So enough from me. We're going to start off with the expert. Professor Rod Moodie is the Professor of Public Health at the University of Melbourne. But he's not just an academic, and this is something that I feel very strongly about. I get sick of academics who are just academics. Ron's walked the walk. He's worked in many parts of the world, including in refugee camps in Sudan. He's worked in the Cameroon and Uganda. And importantly too, he's worked with our own Indigenous population in Alice Springs. And I was just speaking to him a moment ago, and Rob is just about to head off to Malawi to live, which sounds like a very exciting and very important new step in his adventure. Without further ado, I hand over to Rob and look forward very much to hearing what you've got to say. Thank you.
Thanks, Margaret. Thanks very much. Good. Thank you. Thanks very much, Margaret. Thank you for the opportunity of being here. And I've pinched someone else's slide, of course, as one does. What I wanted to talk about, these are the sort of 21st century epidemics I'll talk about, but here's a man obviously lost a leg.
Sorry, Rob,
yeah.
the mic is for...
Sure, okay, sorry. I won't repeat what I've just missed out on saying. But I did want to bring your attention to sort of what's big news. Now, this is obviously a very sad thing for this man to lose his leg. Well, whether it's in the Pacific or other parts of the world, so many more legs are going to be amputated because of diabetic sepsis than landmines, anything else you want to think of. I mean, Filipe was in Fiji not so long ago and talking to the chief surgeon, and who's saying, I'm removing a leg a day. It's terrible. So this is where these diseases are having major impact. Not only are they wicked diseases, they're very, very naughty. They are really difficult to deal with. And one of the things I just want to say to say about the Red Cross, and Robert was here, he's just gone, but I mean, I've been working in this area for a number of years, worked a lot on HIV, but the last few years we've been trying to get other organisations interested in non-communicable diseases. We've been trying to get our own aid agency, as it was, interested, and trying to get the large international NGOs, in a sense like Red Cross, interested. And Red Cross, you are way ahead of the others. And you know, these are big issues. They have to be dealt with. They will have to be dealt with eventually. It is worth starting now, and I'm still, I think I'm very worried the fact that a lot of the other big agencies aren't picking up on this, which then means that the bilateral donors don't pick up on it because they're often hearing and generating their policies as much from what the big agencies like yourselves are telling them as other things. So good on you. Just talking about the 4 big non-communicable diseases and the 4 major modifiable risk factors that we're dealing with. I mean, this is now, you know, globally, alcohol kills more people than HIV, TB, and malaria combined. Heart disease, the leading cause of death worldwide. Over 5 million dying from tobacco-related diseases. These are premature deaths. And 1 billion smokers, 80% now in the developing world, and obviously just millions with diabetes. So these are, and as Margaret was talking about, if you look at Indonesia, for example, not only is 67% of men smoke, 40% of 13 to 15-year-old boys smoke. And that is a big, big train crash on its way. And it's preventable. It's preventable. We can actually ameliorate that dramatically, should we develop the will. There's obviously been a huge changing burden of disease from here where you have the sort of communicable diseases, getting smaller, injuries about staying the same, but the non-communicable disease is really starting to shift as the major cause of death and mortality, death and morbidity. The major attributable risk factors, so the ones we saw before: high blood pressure, tobacco, diet, alcohol use, air pollution, high glucose, high body mass. So all, you know, a lot of these are these are the big issues around the risk factors that are essentially we can do something about. It's not like this is not fixable or not amenable or something where we can't intervene. We actually can. And I apologise. I would have preferred to have this around the Pacific, but the big sort of difference here is that with so many of these diseases in lower and middle income countries, then there's a higher proportion of premature deaths. So not only are you getting very high levels of non-communicable diseases, but if you do get them, then you're going to die of it at a younger age. This is in the Southeast Asian region, but it's also pretty applicable to the Pacific, and in certain countries like Marshall Islands and Kiribati, it's very, very high levels, so that you know you die at an earlier age. So these are again preventable. It's preventable suffering as well as preventable death. The 4 main risk factors, as I said. There are cost-effective interventions available. Unfortunately, we now have some goals and targets globally. There are 3 very cost-effective interventions. If we applied across the globe, we could avert 32 million deaths, and they are salt reduction, tobacco control, and generic drugs for people at high risk of cardiovascular disease. So this is not necessarily rocket surgery. Sorry. but it's doable. And some very good work done by Robert Beagle-Hall and Ruth Benita and others in looking at what is effective. And this is just looking at China, India, so the cost per person per year, and to intervene. And it's because you're doing it at a global level, it's incredibly cheap. And in fact, if you do tobacco control properly, it'll pay for its own way manifold, because the best thing you can do is increase tax. And you use that as a way of reinvesting in your programs. That's what we've done in Australia. Of course, we in fact get a lot more from the tax than we ever spend on tobacco control, but we put that back into our system. And Australia, one of the big things that's driving down Australian levels of tobacco isn't plain packaging, although that is a very good intervention. It's the fact that we've had a 25% increase in tobacco tax in 2010, 12.5% increase in 2013, 14, and we'll have one in 15 and 16. We're now down to 12.8%. That will go down below 10% within the next 2 years, I would imagine. And that's, we're now looking at the fact that what have we done in Australia over tobacco control in the last 40 years? I've actually had a medical student working on this. He's worked out that we haven't smoked 1 billion kilograms of tobacco, which when you line up those cigarettes gets you to the moon 213,000 times. It's the combined weight of New South Wales, Queensland and Victoria, and it's the combined worth of 5 Googles at current cost. So, these are the sort of public health interventions that, if done properly, have enormous impact. We now have globally 9 voluntary targets that all countries, including Australia and all those in the Pacific, have signed on to. They're very ambitious. The big one is reducing premature mortality by 25% by 25, and the big ways of doing this will be around tobacco use in particular, trying to keep diabetes and obesity without increasing at all compared to 2010, salt reduction, raised blood pressure, but also getting people on essential NCDs and on drug therapy and counselling. So, there's absolute hope that we can do things. At the moment, sort of failure is really political rather than technical, and certainly action is inadequate nationally and by development agencies, excluding yourselves, and foundations. Why is all this happening? Well, one of the big drivers are the unhealthy commodity industries, tobacco, alcohol, junk food, junk drinks. And it's interesting, you look at their growth rate in low and middle income countries compared to high income countries, then look at tobacco increase in high income countries, it's 2% per year in low income countries. If you look at soft drinks, that huge increase in low income countries, packaged foods, oils, fats, the same. So they know where to go. They're all heading off into in a sense, the unregulated world, where they know they can actually, they buy local buy local companies, take them over, build them up, run them, and then they actually become so much part of the local economy that it's actually really hard to deal with them. Samoa's a really good example. Now, I've always liked the comparison between the Pied Piper and our local Pied Piper. Same colouring, if you hadn't noticed, but with the same effect on people, and it is absolutely pervasive. In Australia, our kids we have constant, the notion of a Happy Meal, do you mind? Have you seen what's in a Happy Meal? Happy for what? The fact that, it does stagger me, the fact that, you can pack 10 teaspoons of sugar into a can of Coke. They've managed to be able to do that without us really being aware of it. Now, you sit down with someone with a cup of tea the same size as a Coke, and he or she's got a Coke there and drinking away, and you sit there and you put in 10 teaspoons of sugar. They either think you're a nutter or you're severely addicted. It is just weird. They've done it. And we're just sort of going, well, that's sort of part of our culture now. Well, it shouldn't be. And, fortunately, things are starting to gradually change. So what do these companies do? Also, if you think I'm a conspiracy theorist, you're absolutely right. I've been watching the tobacco companies. I was involved in the development of the National Preventative Health Strategy 5 or 6 years ago. We didn't have to talk to tobacco companies. We did have to talk to alcohol and junk food. And I thought, oh, well, maybe they should be in the tent. Better having them in the tent than outside, as the expression goes. I now believe that that's wrong. I mean, alcohol, junk food, they've done everything they can to undermine virtually every effective public health measure, and they're doing this in the Pacific, they're doing this in Asia, and this is Susie Mercado from WHO in Manila who put this together. I love this sort of, this is the policy making process, idea, legislation, hearings, plenary, blah, blah, blah. Scientific research, what do? They try and manipulate it as much as they can. They discredit the advocates that are actually pushing it out. Now this happens in the alcohol and food and obviously now in the energy with climate change. This is really where they're working very hard to do the same thing. They'll use corporate social responsibility to build images. So Coke will invest in bicycles or water, anything in a sense to, hello, look over there. They'll try and get a seat around the table as they did with the Preventative Health Task Force. They'll come out with a pro-industry version. They'll make friends. And then they'll delay and weaken. Or they'll, as they did with the plain packaging here, they'll develop a front group. The Australian Association of Retailers hadn't existed before. Unfortunately, someone leaked it 3 days before the campaign came out against Nicola Roxon. So we had it all before the public did. Get a bit more delay and weakening, a bit of complaining, a front group, and if they don't get you from all this, or they try to subvert the law or avoid any sort, they'll do that. They'll sue you. Non-communicable diseases are different. These are the vectors. These companies are the vectors of these diseases. But unlike the mosquito, they can sue you. So it's not like malaria, but there is a similar sort of pattern. 3P, I'll leave you with it. The 3 Ps of NCD control: prevention, but it's with treatment. In particular, I think in the Pacific, we've got to be able to do both. Persistence, and I'll show you a slide what's happening in Australia, and I think, and Filipe can talk much more than I can sensibly about this, is the notion of prioritisation. We have to prioritise, have to work out what are the 2-3 things we can do right from the menu of 30. There is a menu of 30. We just have to try and limit it to what we actually can do. This is in Australia, tobacco control. In Australia over the last 40 years, now going even further down. But this is about persistence. Each of those arrows represents an enormous amount of advocacy, work, investigation, evaluation, coming together, people working together, and they become additive and supportive. But these build on what happened before. That's in fact the No Buts campaign. It's not No Bulls. And it's survived publication for 6 years, but although there was a lot of bull spoken. Imagine smoking banned on domestic airlines. Imagine, anybody ever seen anybody smoke on a domestic airline? Yep. Imagine if you did it now. Someone would stab you to death with a plastic knife. You wouldn't get off the plane. What we can do here is quite different from there because of community culture. Opinions change dramatically. Well, not dramatically, they've changed over time. And we tried plain packaging here. It didn't work. It has worked here. So that's why persistence is so important. Thanks very much.
Thank you so much, Rob. There is still a bit of an academic in you because we did get lots of statistics, but the statistics were extraordinary. Extraordinary for showing the impact of the problem and the low cost of the solution. What wasn't in the statistics were the obstacles to getting there, and they are big and challenging. And I think I was, at the very personal level, reminded very much of what you were talking about just a couple of weeks ago. I went as part of a program with a group of 14-year-old boys from at-risk families, or the at-risk boys from Western Sydney, and we took them sailing for a week to give them a sense of collegiality and teamwork, and as part of a mentoring program. One of the boys in my group was becoming increasingly agitated over the 5-day period. And I realized that the only things he was eating was milk arrowroot biscuits and white toast. And challenging him on this, he said, well, there's no food I can eat here. And we were having fairly standard spag bowls and boys' food that, you know, and salads and so forth. And the only food he would eat was McDonald's, chicken nuggets and pizzas. And his inability to eat anything else left him at the end of 5 days quite literally shaking as we were coming back into town. You know, his anxiety to get some proper food, as from his perspective. And that's what we're up against. And it's quite scary looking at the impact on the individual. Just one individual amongst millions. Our next speaker is somebody I had the great pleasure to meet a few weeks ago in New Zealand, and it's delightful to have him back in my space. Filipe Nainoca is the Secretary General of the Fiji Red Cross, and when I met Filipe in New Zealand, his presentation was about change. It was about how to turn a movement around in Fiji to enable people to take power over making change and to work at the grassroots within their own communities. I'm not entirely certain what Filipe is going to talk about today, because what he was talking about then was in a slightly different context. But somebody who can do that within a movement within their own country, a Red Cross movement within their own country, from my perspective, is ably qualified to talk about how we can bring about change in this important area today. So please welcome Filipe to the summit and to our country.
Well, thank you, Margaret, for those very kind words. And Professor Rob, thank you. And Peter, of course, I know well. Thank you so much for inviting me to come to share with you today. My team told me, sir, when you finish the slides, you will be a bit of an NCD expert. Of which I'm not. And there are others who are more highly qualified than I to speak on this, but as Rob said, this is, and we are facing in Fiji a tremendous problem. And when we met with the head, the doctor who heads the NCD program in Fiji, he told us we have to treat our approach to NCD the same way we approach a disaster, because Fiji is facing a silent disaster, as he called it. 80% of deaths in Fiji is attributed to NCD. This is incredible. How can such just one particular aspect of a disease have such an impact on a country and its ability to become productive? There are 2 diabetes-related amputations carried out by surgeons in Fiji every day. Rob was kind when he said 1. This was just one hospital. But all over Fiji, there's 2. Every week, I get at least 1 request for wheelchair. 1 request from wheelchair for an amputee. So for us, in Fiji, this is no longer a joke. It is something that we as a national society need to become involved in. And involved in a more detailed way, because the impact is scary, to say the least. As 1 in 3 Fijians are estimated to have diabetes, and most of them don't know. So the reasons for these amputees is that they live in their villages, they don't know. Then they get hurt, and it doesn't heal. And then they use all these traditional medicines, and they go to the nurse, and it gets worse and worse and worse. By the time it ends up in a hospital, it's too late to do anything because the wound is now gangrene. And so what can Fiji Red Cross do? We set about this and talked about it as a team, because NCD, which was previously something that we in Fiji Red Cross was looking at, was not a priority for some time. And we needed to lift our game to see what we could do to meet and to help a government do this. And our approach when we went in to meet with this doctor was we wanted to partner with government in its strategy, using our role as an auxiliary to government to partner in the role of how they were able to reach the communities. And it was very interesting because he had been on leave. We arrived, got the appointment. On the first day he arrived back, and he had an issue, the difficulty in reaching communities. And we came in with a proposal of how we would like to reach our communities with the messages that would help them both identify and also work through the issues that are associated with NCD. And the community support program to practice the behavior, and of course to test. Very difficult to have a Fijian person, either Itoke or Indo-Fijian, to catch a bus down to town, catch another bus to the hospital, join in a queue just to test sugar and blood pressure. They don't do that. Why should they do that? They don't test every year like those of you who are here and my colleagues and myself who turn up regularly every year to do a personal check. Nobody does. It's not what they do in the community. And anyway, they are dead scared about doing it. The hospital is so scary. There are two ways to call a hospital in my country. One is Walenimbula, which is a house of life, and the other one is Walenimate, which is house of death. And so some of them consider it the house of death. They would prefer to remain ignorant until, of course, it happens to them. And there's always this thinking, it happens to somebody else. It will not happen to me. Unfortunately, it's happening. The Australian Red Cross has a CBH-funded program, community-based health program in Fiji. There are 8 communities in which we are trialing in, and these communities have identified within themselves that NCD is a key activity. And so it's interesting to see that the villages themselves are now exercising. I would have thought that they would normally exercise. For goodness sake, take your knife, go to the garden and plant some cassava or do something. But, but now, this is what they're doing. And who's driving it? It's the ladies in the community. They're getting their men out. Today is the day for us to walk. And they actually walk. They walk their men. I was going to say, not like the way you walk a dog, but but they walk with their men, because it's the wives that get impacted. It's the mothers that get impacted, because when the husband, his leg is amputated, that's the breadwinner gone. And so the impact is on the women and their children, and they are more concerned with the men who don't have any concern for themselves. And so the change in mindset in a community is that you have to change the mindset of the men, because the women understand. And we have to change the mindset of the women, because they are the ones who are putting the food on the table that the men are eating. So it's a whole community mind change that we have to work on, and it's not easy. But in these 8 communities, changes are happening. And what we are finding out, much to our excitement, that it can happen. That once the community know that this is impacting their own lives and the lives of their children and the lives of their father, husband, grandfather, wife, even mothers are getting amputated because they are doing a lot of work, they get hurt, and then suddenly they find out they have diabetes. They have no salt, no sugar days. These are days when they say in these communities there's no fun in life. How can life be so sour? Because, you know, the salt makes the food sweet, and also the sugar in the tea makes the food sweet. And sugar is one of our main industries, so in some places, almost you get the 10 teaspoons of sugar that Professor Rob was talking about. But it's happening. And so we are helping these volunteers, community volunteers, translate this action so it can work. And this program, funded by Australian Red Cross, is really helping in our community and helping us to set up a way to get out, because this is slow. More 2,000 villages in Fiji. If we do 8, you know, we'll go underwater, and we're still doing this because of climate change, and we still haven't done anything or reached the whole of Fiji about this community. We have to do something fast, something to get there now. We have to change the way Fiji Red Cross has to change the way it's doing its programs, so we treat it like a disaster response. And so it's important to have branches with active volunteers. Branches have all the focal point to link up with the national, and our recent dengue campaign, which Australian Red Cross helped us fund, will enable us to do that. In 3 months, when volunteers from 13 branches were able to reach 84,000 people. This is individual contact in their home, helping them. And this is what we hope to do. And this is our reach. This is Fiji. These are our branches. The red show our coordinators or the divisional centers. This is in Nainoca, the Western Division, and this is in Lambasa, the Northern Division, and this is Fiji. We are currently absent in the Maritime Zone, and we had a branch in Rotuma, which we are going to revive. But this is our reach. Imagine if Fiji Red Cross, using the reach of our volunteers and our branches to reach our communities with the messages concerning NCD, healthy lifestyles. All of this will enable us to be able to work so much faster, but we have to change the way we think and treat this like an emergency that it really is. And the problem is that while in the higher eloquence of government, they talk about it being important, there does not seem to be any urgency in treating this. And every time we delay a week, 2 people's legs get chopped off, and somebody new gets hurt and does not know. And so we talk about it in our team and say, we're already too late. But that doesn't matter. We have to start now. So what are we going to do about this? Well, we have decided to use the Ministry of Health's focus. Remember, the best way that we can do this is to access the Ministry of Health structure, work within the Ministry of Health structure, get support, formal support from the Ministry of Health, and then use our volunteers to reach the community. Collaboration, we heard this morning, will work really well if we can do this. And the Ministry of Health SNAP approach for consistency. So this is the message, simple. Together with the Australian Red Cross CBHFA, we are developing a manual. So this is how we're looking to work it. Each branch has volunteers. We develop a manual. The manual we train our branch volunteers with. Our branch volunteers take the message to their communities. We conduct this training with the Ministry of Health, together with their nurses or doctors or whoever they support us. All of this will be in this training manual that we are developing through the CBHFA program and the funding they support. Of all people, and I'm sure you probably will not find it strange, the initial start of this program was funded by QBE. QBE came in and wanted to give us a donation. And we said to QBE, we want to start our NCD program. We don't have any money because it is not formally identified within as a CBH, as a program. So they gave us $13,000, on which we are starting this program. And with that $13,000, the team has bought kits. So we have these kits. In this kit, they have a scale, a blood pressure machine, the glucose tester, the height measurement, and it's a volunteer, it's a pack for volunteers. So with this money that we've received, we put in this for the pack for these volunteers. With money from Australian Red Cross to CBHA, we are developing this manual. With support from Ministry of Health, we are now going to formalize all this training, get all this done, and plan with Ministry of Health the communities to target first. So in our discussion with the doctor, we asked him, okay, doctor, tell us, which are the vulnerable communities you want us to target? He said, what vulnerable communities? The problem is everywhere. We have to start now and go everywhere. And we were mainly thinking of rural communities. And he told us the problem is probably more in urban than in rural. So we have to start looking again at our strategy to see how we can formulate this and move in our urban communities. So we agreed, and we are meeting next Thursday in our office. The doctor is coming down for us to meet, for us to select a site that we can pilot and trial this concept. And so we are going to, by the time the manual is almost complete, and we are pushing the team hard to complete it, so we can trial this manual with our people, and then we see how we go in the messaging. So it's advocacy. I'm not going there to heal people. We are going there to say, okay, if you want to have a test for glucose, for blood pressure, for your weight, and get good messages on how you should change your lifestyle, this is what we're going to give to you. And when we find out people who are sick, we then, through the health system, forward them on to the hospital, to the doctors. And of course, the good thing about Red Cross is that we follow up. We don't. And the exciting thing for us is that we have done this before through our TB program, so we actually have the capacity and trained staff who are able to do it. They go, use of blood pressure testing equipment, discussion with MOH, and we asked them, because there was some concern raised, doctor, we have to prick the finger, so the blood comes out to put the glucose tester in. Do you think we should give them the certificate? The doctor told us, oh, well, that's an important consideration, but for goodness sake, you guys do a whole lot more technical activity like teaching first aid to people, and first aid is more complex than pricking a finger to take samples for glucose testing. But there are ways in which you have to do it, and we have to train them properly. These are our challenges that we have in what we do. We are really excited about, so I asked my team, you prepare a program, prepare a whole a budget of how we can go about it to reach our communities. And so they prepared a budget. And so my team asked me, when you go there, ask Australian Red Cross if with Peter sitting there, that we need $160,000 to get the program going and running. But we are not waiting for the money to come. We've got that 13,000. We've got the support from the Ministry of Health. We've been actually asking people who can support us, and the Life Insurance Corporation of India has said, because life insurers pay out a lot of premium for people, it's in their best interest to get all this testing done. And so we tell them, give us some money, because we are going to help you save on your premium that you pay out if people know well beforehand that they have this. So at least we can go into some preventative programs. That's it. Thank you. So thank you so much, Margaret. I know I've spoken for long. I tend to speak too long sometimes. But thank you for your kind attention. And we hope that we can do something for our country and maybe share with the Pacific. Thank you very much.
Thank you very much, Filipe. I think we might leave questions until the end if everybody's happy, because I think that what I'd like to hear is some interesting reflections on the questions from all three speakers. Just unless there are any very specific technical questions that you'd like to ask Filipe, just points of clarification. Happy? Okay. It's not moving on to the next one, as it should. Maybe, Peter, you can... I was reflecting while listening to Filipe about the question of where Red Cross has come in 100 years and where it will be in 100 years' time.
Leave your name up. Yeah, exactly. In case I say anything silly.
I think the theory is it goes back to all three, but yeah. And 100 years ago, a group of women got together and recognised a problem and worked collectively to find a solution. And we heard Filipe talking about 100 years later, a group of women recognising their role in finding solutions to problems. And I think that's one thing that Red Cross has been extremely good at, is giving women the opportunity to contribute to finding the solutions to complex problems, being part of the solution. Supported, of course, by jolly good men. I think Filipe's presentation was also a wonderful example, again, of what Dawn was talking about, the need for a multi-sectoral approach to resolving complex issues. It is not something that can be just done by any one agency or any one entity. It has to be done in collaboration between relevant partners in a country like Fiji, not just within the country, but within the region as well. And it has to engage with people at the grassroots, ensuring that they understand the relevance to them and that they walk with Red Cross and with the Ministry of Health through finding the way to deal with a severe issue that is presenting. Our third speaker, Peter Walton, is somebody that I feel very privileged to have had the opportunity to get to know over the last year and a little bit. I think it's, 13 months or so since he has joined the Red Cross, the Australian Red Cross, as the head of international programs. Peter has brought great energy and professionalism to this role. He has changed the way that the board has looked at the work that is being done, and I have been enormously impressed about what I've seen. Peter's got an extraordinary background in the field, having worked in or been associated with work in over 40 countries, including 7 years in Vietnam. But he's backed that up with sound academic background, including an MBA, which is something that you don't often see in this area, but I think that it's a qualification that brings a range of important disciplines together that are very relevant in finding strategic solutions to issues. Peter, over to you.
Thank you, Margaret. And good afternoon, and thank you, Rob and Filipe. I'm going to try to put a slightly different spin on this, or a different angle to NCDs. And I think it in some ways will also build on the conversation that Dawn started in the plenary around collective impact, and how if ever we're looking for a complex problem, NCDs are a complex problem. And I want to talk about that, and I probably want to pick up on Rob's third P, prioritization, and why NCDs aren't getting the prioritization that we deserve. I mean, we've heard pretty compelling cases for why NCDs should be much further up the agenda. The fact that a couple of people a day can be presenting to a hospital in Fiji to have an amputation, would suggest an urgency which isn't reflected in current global policy making or aid decision making. But just before I go into that, I just want to start with, let's dispel some of the myths around non-communicable diseases. Non-communicable diseases are not a disease of the future. They will be a massive problem in the future, but they're absolutely a problem that we need to deal with today. The fact that they are already the leading cause of death and disability would suggest that we should have people screaming with urgency and activism that just says that this is not acceptable. Because as Rob highlighted at the beginning, so much of what we're encountering is preventable. NCDs used to be referred to as diseases of the rich or diseases of the aristocracy. Yet we're not seeing that now. We're seeing that over half the people with NCDs or more, I think, are actually in developing countries. I think it's closer to 80%. We're also seeing that NCDs both cause, result in, and perpetuate poverty. And we're also seeing that NCDs aren't just a disease about aging. Over half the people that are suffering from some form of non-communicable disease are under the age of 70s, and we're seeing rapid escalation in issues with children. NCDs are also, and we've heard this many, many times, not a disease about laziness. Not about people just getting more and more obese and not engaging in exercise. They're largely an issue around how people have opportunities and the access to the opportunities that they have to lead healthy lives. And critically, and I guess the point that I want to spend most time talking about is NCDs aren't just a health issue. They're not just a technical issue. They're absolutely a complex, interconnected political crisis that we're facing. And I really want to talk more about that, as I think there is so much more that we can do. Look, I feel really pleased and humbled that both Filipe and Rob have credited the Australian Red Cross as being one of the few agencies that's doing something around non-communicable diseases. But in recent months, we've been doing a lot of reflection around, well, what more could we do? What are some of the dimensions of addressing non-communicable diseases where we might seek to take a different approach to complement the efforts that we've done thus far. So let's start with why isn't it higher up the agenda? Hands up if someone can just name the Millennium Development Goal specifically that addresses non-communicable diseases. Sorry, I don't want to name and shame anyone, but Usman, I see someone's pushing your hand up there. Look, it relates to pretty much all of them. It relates to maternal health, it relates to poverty, it relates to HIV/AIDS, it relates to childhood development. But only 14 years ago, or slightly more than that, when the Millennium Development Goals were being formed, NCDs weren't really part of the dialogue. They just weren't. Even today, we're only really just getting some traction around the impact of NCDs on poverty, on people's well-being. I just find that extraordinary. I just find it absolutely extraordinary that what is now regarded as the leading cause of death and disability and all the associated factors linked to that wasn't on the agenda for something like the Millennium Development Goals. And I'll come on to, well, what do I think that means for post-2015. But let's be really, really clear. It will be absolutely impossible to eliminate poverty and address issues of vulnerability if we don't get our heads around addressing NCDs now. The costs of actually dealing with non-communicable diseases in the future will grow exponentially. And we've seen that in Australia. The costs of tertiary level healthcare are extraordinary. It is much more cost effective to deal with prevention right from the outset. They actually pose, non-communicable diseases, a bigger threat to economic development than infectious diseases and natural disasters combined. And just think about that for a moment, because the Red Cross is largely known for dealing with natural disasters or responding to emergencies. But we are dealing with a ticking time bomb when it comes to non-communicable diseases. It's not going to explode all at once, but it's going to really present enormous challenges for us as we move forward. They have been something which is absolutely perpetuating poverty in the current age. Whether it is the cost of dealing with expensive healthcare, whether it is dealing with amputations in Fiji, so much more needs to be done. But it isn't just a health issue. It really isn't. And Margaret touched on this before, that the importance of recognizing that it's a multi-sectoral approach that needs to be considered is really critical. It isn't just health. So let's just think about it. NCDs are impacted by our approaches to how we deal with agriculture, our approaches to how we deal with food security, our approaches to climate change and the environment, our approaches to how we deal with issues within environments, and also, and most specifically, I would say, issues of trade. Trade agreements and foreign direct investments have an absolutely enormous impact on a country's ability to ensure that its population is healthy. We've seen, especially in the Pacific, with the Pacific Island country trade agreement, increased risks around non-communicable diseases because of a reduction in trade tariffs. So that, and also limitations in terms of health policy implementation, where people are giving access to markets, and it ends up resulting in poor life choices being made because access to markets, whether it is tobacco companies or alcohol companies or imported processed food, it's really being pushed upon a market in a way which is having sort of devastating consequences. Climate change is also absolutely having an impact on non-communicable diseases in terms of the adequacy, the availability, and the stability of food supply. If you're living in a poor household, and it's going to be easier and more cost-effective for you to make an unhealthy choice than it is to go for a nutritious choice, homegrown fresh food, what would you make? What choice would you make? People are making choices often because of the opportunities of access, rather than because they're simply making what would be the wrong choice. And I think so much more needs to be done. And I think I don't need to go into it anymore, but I think Rob really articulated some of the challenges around the roles and the ethics of some companies, especially in the tobacco industry, where, despite knowing the facts and the science, and whilst disputing it, inroads into new unregulated markets are prime pickings for large companies, and we are seeing enormous consequences from that. Now, we do know that there are many things that we can do to address this. Tax increases were one, smoke-free workplaces are another, bans on advertising. There's a whole range of things, but it does need to be more. There needs to be a range of things which really try to have a much different, more collective response. So when I listened to Dawn earlier and she started talking about a complex social problem, largely place-based, we think about just Fiji. If this isn't a complex social problem, what is? Is there a common agenda to addressing it? No, there isn't. There's a health agenda, a splintered, fragmented agenda which deals with health issues, not one that necessarily deals with issues of trade, issues of climate, issues of regulations of how business is conducted in a particular country. And I also think we have been incredibly slow in terms of a global response to non-communicable diseases. We've been slow in recognizing the problem. We've been slow in action. We've been absolutely slow in terms of both a public health response and an international aid response. And it still isn't really on the agenda of multilateral and bilateral donors to any large extent. I was having a conversation with a friend from the World Bank based in Washington, and he's actually going for a senior job with the World Bank office in Sydney, and he asked me to send through some information on what I think are some of the critical issues in the Pacific. And why, obviously I mentioned climate change, but I also mentioned NCDs. And his response was, that's interesting, it has never come up in conversation in my preparations with anybody. And again, I find that absolutely extraordinary that something that is so critical for the region is not being discussed. And I think a consequence of that in terms of prioritization is investment has been woefully inadequate, completely mismatched with the scale of the problem. And there has also been, unlike many other, I guess, social movements which are really addressing complex social problems, we haven't really seen the same level of buy-in in terms of activism. So everyone's heard of Make Poverty History. We hear about the efforts around climate change, all admirable, all things which we should support. But there isn't really an approach dealing with non-communicable diseases which is trying to mobilize action in the same way. It is getting there slowly. And over the recent years, there's been high-level meetings through the UN system, World Health Organization, and we now have some global targets. And again, Rob outlined some of those. But an action plan for these was only agreed last year. Only 12 months ago, an action plan was put together to deal with what is the leading cause of death and disability in the world. So it's extraordinarily slow, and we've got a lot of catch-up, an enormous amount of catching up to do. Now, international organizations like Red Cross have a critical role to play in this. I think we have a critical role because we engage in direct programs around health. We deal with direct programs around youth and looking at how we advocate healthy life choices with young people. We work in terms of disability inclusion. All of these things fit together. But we're thinking increasingly, what more could we do in terms of having a more joined up collective approach? Here in Australia, there are specialist organisations that deal with aspects of non-communicable diseases. You know, the Cancer Council, the Heart Foundation. You know, different organisations can play a different role. There are organisations focused on dealing with issues with young people, organisations that are looking at issues of advocacy around trade rights, intellectual property. We're not joining up the dots, but I think so much more can be done, and so much more needs to be done, especially in terms of the education and advocacy component of making sure that non-communicable diseases are further up the agenda. Look, I think there are some things that we can really push for. One is looking at, I guess, more bold health policies, ones which do try to shift the emphasis more onto prevention and primary care, away from what we have at the moment, which is more and more investment being pushed into tertiary level care, dealing with problems after the fact. I think we need to move beyond blaming the individual for their circumstances around non-communicable diseases. They are largely, I guess, the outcome of the lack of opportunities that they've had, but we do still have a large amount of dialogue around blaming the individual for being overweight, blaming the individual, and I think we've got to move beyond that. Absolutely need stronger advocacy, and we need to do more to, I guess, remove the stigma. But I think finally, we also need to lobby and influence government, bilateral aid programs, so that they have a much better convergence of both the social and the economic agenda. We have at the moment, a strong focus on the economic development components of the aid program, but largely it will count for very little if we're not also addressing some of the social consequences of such choices. Thank you.
Thank you very much, Peter. So reflecting as I was listening to Peter about the challenge ahead and thinking back to Lucy's presentation this morning about the power of people to change attitudes. I mean, we saw in Lucy the most impressive young advocate. We saw in Kathy, the woman from the Marshall Islands, somebody who is a champion for a cause. And I think what Peter is saying to us is that we need champions for this cause too. This is one that is every bit as important, every bit as great as some of the other issues that are on the agenda here at this summit over the next couple of days. And I think that Red Cross is ideally suited to be that champion for this issue, or to be one of many, hopefully one of many champions for this issue. The Red Cross is an organisation that can work at the political level. It can work at the community level. It can educate individuals. The Red Cross is an organisation that can mobilise the power of humanity. And it's something that we should be doing in this area. So I think this is the challenge that has been presented to all of us and to all of us collectively in this building at this time, to take this message and go forth with it. And I think that we have some very able leadership and guidance from Peter and his team in this regard. But over to you now. Have you got questions or comments that you would like to make? And when you stand up, please identify yourself. Desley.
Thank you for that. It was really interesting. My name's Desley Village. I'm on the MPAC committee.
Would you like to explain the
Migration Program Advisory Committee for the Red Cross, and I'm also on AHL committee for South Australia. I've got two questions, probably directed more to Rob, one to Rob and one to Filipe, if I can. Firstly, Rob, you made some mention regarding the Framework Convention in relation to tobacco and the regulatory framework in relation to that. And more often than not, that's probably applicable in developed nations, as we traditionally used to call them first world nations, and those sort of developed nations already. But the problem in relation to tobacco in many of the developing nations is in fact because of the illicit trade in tobacco and much of the illicit trade in tobacco, and they're not necessarily compliant with any of the regulations under the Framework Convention necessarily, nor have they the resources to actually sort of apply the regulatory framework. I was wondering where in that sort of discussion regarding health and a discussion regarding illicit trade, is there any sort of window that a dialogue can occur in developing nations as to how they can actually, and often tobacco companies are complicit, and there have been a number of prosecutions in relation to that, they're complicit in relation to the illicit trade. I mean, where is there a place for dialogue in relation to illicit trade in tobacco, how to actually have some advocacy around that in developing nations, because it is often the illicit trade that actually targets the poorer countries, the countries that are much more vulnerable, and does that contribute to the higher rate of problems within developing nations in terms of tobacco? So that was my question to you. Filipe, my question in relation to you, you made a comment regarding a movement of people from the rural community into the urban community, and that has its own challenges as well. What I was interested in knowing in particular is, and this is important I think in advocacy, are there less figures, figures of harm in the rural communities? Do they increase when they move to the urban communities? And if so, has there been any discussion as to why that might happen? And then some advocacy in relation to that. Thank you.
Yeah, thanks. I'm not sure how much the illicit trade actually, how important it is. It's often overstated. In fact, by the tobacco companies. I mean, they always overstate it. Say, well, you bring in regulations and up goes smuggling. even though, as you say, they're often complicit in it. But I think, on the other hand, it is absolutely real. I think in so many countries, I mean, whether we look in Pacific or we look in Southeast Asia, then the problems are so huge that we can start with the illicit trade, and if we could just bring that down in Indonesia by 50%, we'd be doing an enormous amount of good. It's in terms of prioritisation. It is about starting with the illicit trade, I think, and really trying to get that down, because that's actually about helping to change the culture. And once you start to get a movement and a change in culture around, for example, smoke-free regulations, then that changes the way people look at it. Once people start to understand that they're inhaling other people's smoke, that puts them at risk, then it changes the dynamic of the conversation. You're not wrong at all. It's just a question of, becoming prioritised, and where do you really start? Probably starting with illicit.
Thank you for your question, and the answer is no. We do not have information of whether the severity of the disease is more in urban or in rural, but we know that it is present in both areas. And in fact, the urban problem increases because those who come in from rural seeking medical attention stay in the urban areas, and it is not helped because the dietary habits of those in the urban are different from those in rural areas. And the issue in rural areas is that their dietary behavior is also changing, but the knowledge of the impact of the disease is absent, or the diseases is absent, while there's probably more knowledge in urban areas, and so the impact is higher. But certainly it would be something that as we start this program, to begin to capture these statistics, which we did not intentionally try and capture before. So it is something, as we are in the beginning of the programs, is something that we are looking to try and capture. Thank you.
Thank you. Jill Lester, member of the International Committee. I've been struck by two sentences I've heard today that really stuck in my mind. This morning, Lucy said that she found education disempowering, which was really quite sort of stunning.
Do you want me to have a part of that? I mean, I don't necessarily think there are. I mean, this is going to take a long slog. These are very difficult, complex problems. They have major economic interests driving them, have major cultural shifts. Why has so much sugar and so much salt become part of Fijian way of life? Well, it's not just hasn't happened spontaneously. It's happened because it's changed. I mean, someone's been working to change our palates for the last 30 years, and it's going to take a while to change those palates. I mean, the fact that people saying that doesn't mean that you can't do anything about it, and we can't diminish the salt and sugar in our food. We can very successfully. If we can reformulate the amount of salt in our food in the next 10 years, no one would notice. You could do it if the industry was compliant. They're not compliant. They don't want to do anything about that because they'll lose market share. And unless you have governments coming in and saying, okay, you have to do this all, that creates an even playing field, therefore everybody doesn't lose market share, then they'll do it. But no one's going to do it by themselves. In fact, I think one of the companies tried it and it didn't work. I mean, interesting, overnight, a major report was produced by McKinsey's looking at obesity globally. And it's interesting that a mob like that have come out saying, look, you really have to be able to use regulation and policy change and market interventions around cost to actually shift behaviour. And I think that's going to be really tough. It is going to be tough because we've got such a big fight on our hands. On the other hand, companies aren't going to just suddenly change overnight. We have to be able to I mean, in some ways, it'll have to be driven by community opinion, and that's why I like. I think, as you were talking about, the role of someone like of a group like Red Cross is you can use your relationship to community to influence political power. In other words, you've got political connections because of community respect connections that exist, and not all organisations have that. And that's a very powerful thing to use in terms of when you're negotiating with government. You say, well, this is what our volunteers say.
If I could add a couple of other comments. Margaret alluded to the fact that I lived in Vietnam for 7 years. When I got there, KFC wasn't there. McDonald's, Starbucks, none of those large multinational organisations, retailers were there. But they had all registered. They had all pretty much registered their intent to be there. They'd secured trademarks and so forth in Vietnam. And I happened to meet someone that was associated with McDonald's, and they said that they were planning for rapid scale-up, but they were waiting on a couple of things. They were looking at average household income, especially within the cities, and they were also looking at the sort of the current appetite for more Western-style diets and how they could influence that. And you know that pattern is well established in Vietnam. So there aren't any silver bullets, but we have been talking quite a lot with, including with Dawn O'Neill, about collective impact. You know, and this idea that it isn't a quick fix, and I love the African proverb: if you want to go fast, go alone. If you want to go far, go together. Because I think if we had a common agenda, if we actually had mutually reinforcing activity, if we actually had some shared measures and a longer term time frame where we were basing success not on individual attribution but collective, the contribution and what that adds up to, then we'd go a long way. And I really do see that the Red Cross could be a backbone organisation. We have the connection with communities. We're genuinely local everywhere, and we have the connection throughout pretty much every territory. And you know how we might seek to leverage that so that we can have, I guess as you say, Jill, a different approach to a complex problem, one that isn't splintered and fragmented.
I'd like to comment on that comment that you stated on education being disempowering, and it is right. And we have had to look at the way we change our messaging, because the previous messages that went out was, don't eat this, don't eat this, don't eat that, that's bad for you, and if you eat that, that will do for you. To change it to, would you prefer to be healthy and do the things that you really want to do in life and eat this instead? To move away from the don't, because the don't was quite depressing. As was stated today, that's true. If you eat this, if you eat this, if you eat this, then this is what you'll get, so don't eat it. To change the messaging to say, you can be really healthy if you eat this, and if you are identified with high blood pressure, that you don't have to drink tablets to control it, you can actually change your diet to be able to control it. And it's this message that we are trying to put together to give out, to change the way we're doing it. And yes, we quite agree with the statement. Thank you.
Hello, I'm Michelle. I'm actually here from a different perspective because I came to workshops that I really don't have any involvement with in Red Cross. Just to, further expand my exposure to what we do and stay connected. I first came into Red Cross about 2 years ago in fundraising and marketing, having 8 years experience in not-for-profit world, whether it be in drug and alcohol rehabilitation for youth, Cancer Council New South Wales, Greenpeace, and then into Red Cross. And I think, now, and after being in fundraising, now I've moved into reporting and business improvement for marketing, fundraising, and communications. So probably a very different perspective to most people in this room, but me and my colleague Nigel were also just speaking, and I agree with what you say here. When I listen to, what is being said and it being about education and it being, disempowering, we used to have to deal with that in every public piece we would put out. It was always fear versus emotion, balancing them both, emotional, rational, irrational. And it really does come down to the marketing message and the message that goes out, which is exactly what you said. And, if people viewed fundraising and marketing in a way of getting that message out and stories to be told, there are other ways that you can get education. And the other thing we were saying as well is most people wouldn't view it, the splintered approach with Cancer Council New South Wales or Cancer Council Heart Foundation. No one in Australia really views it as the large issue of NCD. You know, you've got all of these people going, this is an issue, this is an issue, this is an issue, and all in themselves they are big issues. But if you were to actually get into Australian or any country's mind that all collectively, these are actually the biggest problem that we're facing, is how you start to get people to view it differently. And I think that, you know, listening to Peter was actually quite interesting to me, having worked in a few of these different organisations and the approaches they take, none of them really coming together to go, let's look at this holistically and what can we do together to beat it as a whole, rather than just this is what we're looking at. So it was just interesting for us to listen and think there are a lot of ways that we could change the messaging to not make it unempowering.
Thank you.
Did you want to respond, or is that self-evident?
Thank you for the comment. I mean, look, I think getting organisations working together where there is a shared goal and a common vision is essential. You know, Cancer Council, Heart Foundation, other specialist organisations, you know, they have very unique and more discrete work that they also need to do. But I think it is about finding the commonalities where the pieces do fit together. So, you know, I think it's a great comment.
Can I just say tobacco control has been a really good example where people have worked together incredibly well. I mean, that's a huge success. And you've actually had the major drivers of good tobacco control, which are in cancer councils, in the Heart Foundation in particular, have worked very well over the last 30, 40 years. So there are some really good examples where there is a common agenda. And the states have actually driven this as well and finally dragged the Commonwealth, depending on who's sort of in control at the time. But it's become a non-partisan issue as well. It's become a politically non-partisan issue. So it doesn't, what political party A does isn't ripped down by political party B when they change office. And that's a very powerful thing when you look in success in Australia, is that when there's a non-partisan approach, that really helps. But that's often driven by very powerful, good champions, good organisations that underpin them with good science and good evidence.
But replicating that success in less regulated markets is, I guess, is part of the challenge.
Yeah.
Hi, my name's Brianna and I'm from the ACT Youth Committee. I think it was Peter who touched on the idea that non-communicable diseases have previously been seen as maybe a problem of the first world or the rich, and whether you think that's what's stopping it being put on a development agenda still. And then following on from that, whether you think the solutions proposed about regulation and control at the government level, and then about sort of promoting exercise and healthy eating at a personal level are appropriate solutions in a developing context, or whether they're luxuries, perhaps. Because as was sort of stated, whether the regulatory framework in those countries is there to support it.
All of the above. I think it goes to Jill's earlier question that I don't think there is a silver bullet solution. It's a multifaceted problem. So efforts to promote more physical activity, efforts that or regulations that can actually provide better health policy outcomes. I think these are all absolutely welcome. I think there is still a long way to go in terms of overcoming the myth around NCDs being largely a rich country or a rich person's challenge. It's not backed up with the science or the statistics anymore. But I think that comes down to the advocacy, making, and also having some social mobilisation that really puts this on the agenda. And I think that's what has been sort of missing. There have been efforts, but it hasn't got the traction that I think it needs.
I'd like to add to what Peter said, because the problem is incredibly complex and it's at different levels, and you have to attack it at all these levels at the same time to have it really become effective. But different organizations are effective in different levels. For instance, we are effective down at the community level. But yet, and there needs to be someone also advocating in the political level and the statutory levels. These all need to happen at the same time. But unfortunately, it is not coordinated that well because, as we have heard today, not many think that it is such a big problem. And if we don't, then, of course, while we can move forward in a certain aspect, for instance, in our role in the community, there will always still be that lack, still be that gap that cannot be filled. So how to fill that gap will continue to be a challenge. But in Fiji Red Cross, we have decided that we need to do something. We see the complexity of the problem and the need to target it at all these different levels. But we have chosen to pick the area that is of our strength, the area that we can have the most impact, and work together with the Ministry of Health to be able to do it. The next step, of course, in what we are doing now, after we set our strategy with the medical officer that is responsible for this NCD program, is then make a combined presentation to the minister. So at ministerial level in government, which then ends up in cabinet, they need to understand that the reasons why and what is happening at our level. But that can only be done by the minister, but we need to start somewhere. So we actually haven't started yet. We are in the process of getting started, and ask me in December 2015 how we've gone, and I hope to be able to share some success stories. But I can tell you that even for us, the complexity of the need and how we should attack it is daunting. And so we have chosen to do what we believe we can do.
Can I just add very quickly, they don't affect children, generally. I mean, in a sense of getting the community sympathy. They're not communicable. In fact, they are by virtue of the nature of society. But I mean, there's no, it's not an Ebola or a measles or even an HIV. And there's no people living with, people living with diabetes as an active political force, like people living with HIV, or people living with stroke, or people living with cancer. It's not a, cancer's actually started globally. I mean, with the Relay for Life and the breast cancer's been enormously powerful advocacy in Australia, but generally those sorts of movements haven't started. But for you, do you know about NCD Free? Get onto the website today, join up. It's a global social movement started by Sandro DeMay and his brother out of Melbourne. The UICC's the conference is here in 2 weeks' time. A lot of action happening around NCD Free. So it's all young people advocating around NCDs. There's also a YPCD, Young Professionals Chronic Disease Network as well. Again, a great global group just starting, driven by young people around NCDs.
I'm Barbara Holland from Australian Red Cross in Western Australia and responsible for domestic programs. And I'll, in the interest of getting you to sort of healthy afternoon tea, I'll keep it to a bit of information sharing. So we've been delivering intensive healthy lifestyle food literacy programs in Western Australia since 2005. We think we were, taking the lead in Australian Red Cross domestically. Over the last 3.5 years, we've been working in close partnership with Cancer Council WA and Food Bank WA on the delivery of statewide intensive healthy lifestyle programs. For the first 3 years, they've been evaluated externally by the University of Western Australia, and the evaluation results show that through intensive food literacy programs that target all of the NCDs, that it is possible to influence behavioural change in a sustainable way with the most vulnerable and at-risk target groups. who are for us low-income families, Aboriginal communities, and people from culturally and linguistically diverse communities. So I just like to say it. I don't think all education is disempowering, and it's the way in which you deliver education that can make it incredibly empowering. And my question was going to be, do we think that we get more bang from our buck for investing in mass media campaigns than in intensive health promotion campaigns, or do we simply just need both?
The latter. Yeah. You need good social media campaigns. I mean, it's, the government delivered on this stop it, what is it? Stop it, don't. Swap it, don't. Some, a completely useless program, was poorly researched. Someone had the idea, let's create a norm thing that we did 40 years ago, which no one ever actually evaluated whether it worked or not. But I mean, now fortunately with the Live Lighter campaign, they're bringing in stuff that's been well researched, well developed, and you know, crap social media does not work. It's got to be well researched. And I mean, whether you're talking about education, is absolutely the type of education. If you just rely on school-based education done badly, again, it probably won't work. But we are, you know, about changing ideas, cultures. I mean, it's let's learn from the advertisers. They know how to change influence of behaviour.
I'm hoping that you will indulge me for one last person. I know that we've sort of got about a minute left, but I think it's been so fascinating. I'd love to hear a tiny bit more before we go to afternoon tea.
So I'll be quick. My question is for Filipe. It's Wayne Sagol, Work Health and Safety Manager for Australian Red Cross. So my question is, so you've mobilised your volunteers in Fiji, which is fantastic. You talked about the fact that there's 2,000 villages. I just wondered whether you've also engaged with community and or opinion leaders, or whether that's something that you might also want to consider as part of your program.
Thank you. Yes, we will be working with community leaders. But the concept is this. Our volunteers have what we call low-cost activities. And low-cost activities which they do, which they pay out of their own pockets or with minimal funding, and to empower them to visit communities. So this is part of that program, because one of the things that we have been looking at is how can we extend and work this program with minimum funding, with as little money as possible, but maximum reach. And so these individual branches have about an average of 20 to 30 volunteers. These volunteers are divided into 4 different departments, so to speak. And so the health volunteers that are responsible for this are then the volunteers who are going to be trained to conduct this training. They then, as part of the branch, which is independent and they do their own thing, decide on the communities together with the guidance of the local government authorities or the local health authorities, and they choose which communities they feel and they've assessed as the most vulnerable in their district to visit. And then they plan these visits to go out. National office does not have anything to do with this planning. This is important because if we planned, I have 32 staff. My health team consists of 6 people. And the only way we can multiply our reach is to give this and empower our volunteers to be able to reach their communities. If we don't do this, then we'll be waiting till Fiji goes underwater and we still wouldn't have reach. So this is the concept. And we have seen it work with our dengue outreach program, being able in 3 months to reach 86,000 people, 4 national office staff conducting training to 200 volunteers out of the 14 and empowering them to reach their own communities. So we have a model that works. And we are working through this model, and we hope by giving them and increasing their encouragement, they will be able to accelerate the reach. So what does it look like? They turn up to a community in a Red Cross tent. They put the Red Cross tent up in the community. Before getting there, they've done the PR in the community and told them we will be coming. They have all the people sitting there that do the blood pressure, and all the community are invited to come, and it's for free. The money to pay for the strips, the pricks, and all the transportation and everything is brought in by a local donor. So they visit a shop and say, can you please give us $200 to pay for our transport, we are going to visit this community. This is the model. It allows the branch itself to determine and to work without anything to do from national office. Of course, we do the training, we do the monitoring, and we set the baseline on the data that they need to collect. And during the visit, they visit, if possible, with a local health nurse and in coordination with the local village nurse. So everything is coordinated, and the data is then transferred up to Ministry of Education. They lack data that only in this kind of program can be reached. It has to be pre-thought, prepared, and logged, and made ready. But it's an incredibly powerful way of reaching our community, and we are telling the people of our own branches, these are your people, your district, your community. If you care for them, you will do this for them, and they're waiting for us. It just happens we're a bit slow in getting all this ready.
Thank you, Filipe. I began by saying that this workshop was chosen for me. I didn't choose it. I have come to the end of it feeling enormously privileged to have been able to be here to listen, and enormously challenged by what I've heard. I'll finish with Filipe's words. We all need to change the way that we think and to treat this as the emergency that it is. The challenge to you as individuals, the challenge to you in the lives that you live, and the challenge to you most importantly as Red Cross people. Please join with me in thanking Rob, Filipe, and Peter.